Hi, my name is Chris Bashi. I'm an emergency physician at Mercy Hospital St. Louis. Today we're going to talk about respiratory distress and respiratory emergencies. 10% of the EMS calls we respond for are for some element of respiratory complaint. We go to a lot of other calls, for example, chest pain calls or maybe trauma patients that have respiratory complaints in addition to their chief complaint. So this is something we encounter fairly frequently out in the field. How do we approach someone that's having shortness of breath? The initial size up should look at the patient's airway status. The way I will often characterize this in my chart is how the patient is speaking. If they can speak full sentences, short sentences, maybe only one word at a time, or maybe they can't speak at all. That's a good indication when you're documenting or when you're sizing up the patient as to how short of breath the patient is. We want to make sure we do a detailed history. We want to go ahead and do all of our PQRST questions. We need to get down to exactly why this patient is short of breath, and there are many possibilities. Maybe the patient has a history of some respiratory problems. Maybe they don't. You have to ask yourself, why does suddenly someone who has never smoked a day in their life have COPD or asthma for the first time at 2 o'clock in the morning when this is most likely an element of congestive heart failure instead? So make sure you get a detailed history, ask a lot of questions, ask family members, bystanders, anyone else you can get history from. And then you also want to do a detailed physical exam. Do they have edema in their legs? Are they having rales? Are they having wheezes? Have they been coughing? So these are all things that we need to be looking at when we're approaching these patients with shortness of breath. We want to make sure we also apply a cardiac monitor and do a 12-lead EKG on all of our shortness of breath patients. Substantial energy is used when you are short of breath, okay? It takes a lot of work for these folks to breathe, especially our folks that are in congestive heart failure. They have a lot of fluid in their lungs are very wet, they're very heavy, they're trying to move air in and out, and so what you need to do is watch very closely for signs of decompensation. If the patient starts to lean over and is not as responsive, and is maybe taking more shallow breaths, that's an indication you may have to intervene and assist that patient with ventilations. You want to make sure you sit the patient upright in almost all cases. You want to make sure you loosen any restrictive clothing, and make sure we can make it as easy as possible for the patient to breathe. And certainly don't walk these folks any distance out of the house. I mean, if they're significantly short of breath, we need to make sure that we're not asking them to do any more physical activity than they have to. Okay. Oxygen can cause harm, okay? And this is different than what a lot of us may have been taught years ago when we went through paramedic class or medical school. We used to say, well, we just throw everybody on a non-rebreather. Well, what we're finding now is that when we use oxygen is a drug. It may cause harm, and when we give it, we need to give it for a good reason, okay? There's no need to give oxygen if the oxygen saturation is not low in most cases. We find this is especially harmful when oxygen is given in large quantities to patients with COPD, trauma, MI, and stroke. So a lot of these cases, we're talking about tissue injury conditions like trauma, MI, and stroke. They do actually worse down the road if they were given a bunch of oxygen up front. So if you got somebody with a heart attack who's having some shortness of breath, his oxygen saturation is 94%, there's no need to throw that patient on a non-rebreather mask or even a nasal cannula, okay? I'm sure we've all seen these oxygen bars out in places like Las Vegas where you can pay some money and sit and have some oxygen delivered to you. It's silly, okay? First of all, you can't get your oxygen saturation greater than 100%, and it also could be harmful in some of these medical conditions. So how do we deliver oxygen? Well, the first thing we can do at the lower end of the spectrum is use a nasal cannula. When you're breathing at room air, you have about 23 to 24% oxygen. When we add a nasal cannula at 1 to 6 liters per minute, you can increase that FiO2 to about 24 to 44%. Now that will elevate substantially when we move to a non-rebreather mask. Here we use at least 15 liters per minute of oxygen. We have an FiO2 we're delivering now of around 90%. This is called a non-rebreather because you want to make sure the patient doesn't rebreathe the air that they're exhaling. So there's some ports on either side of the mask that allow exhaled carbon dioxide to exit the mask. And then we have a reservoir bag that we should make sure we fill before we put this patient on this device that will provide additional oxygen. The non-rebreather part of the non-rebreather mask is they don't rebreathe in the air that they just exhaled. and we have a nice oxygen reservoir for them to pull from, and that'll generate an FiO2 of 90%. Now the bag valve mask, here we've stepped it up a little bit. This is our first device where we provide not only oxygenation, but ventilation. Okay, so we're providing some breaths with this device. It requires a good seal. You want to make sure you know how to do the technique, and we'll go over that in a minute here. You can use some cricoid pressure. There are some folks that say we shouldn't be doing that. I mean, there's a little bit of discrepancy with that, but in most cases, you can apply a little cricoid pressure to help get the air from going down into the esophagus. That can lead to vomiting and aspiration. We use a lot of supraglottic devices now, so it's very rare that we should be bagging a patient with just the mask. So make sure you use an oral airway or a nasal airway at the bare minimum. But in most cases, if we're going to use this device, we're probably going to place a supraglottic airway, if not an ET tube. Now, the EC technique is one where you put the mask on the patient's face. You use your thumb and your index finger to make a C to hold the mask on the face. The other three fingers of your hand form an E, and those are used to lift the jaw into the mask. And that's something that needs practice. You can practice that on a mannequin. It will allow you to get a good seal. What you don't want to do is lean on the patient's face. Okay, a lot of direct pressure on the face to kind of force the mask on there. That's not exactly the best technique. The best way to do it is just stabilize the mask with your thumb and index finger, the C part of this, and then using the three fingers that form the E to lift that angle of the jaw up in there. And it helps obviously if you have a big hand. If you're having trouble with this, you can do kind of a double EC technique where you use both hands and actually lift the jaw into the mask and stabilize it with the thumb and index finger on both hands. But that would obviously require someone else to then squeeze the bag. All right, let's talk about CPAP. This is another thing we can do. This is in addition to the devices we've already talked about. I think all of us are carrying a CPAP device of some sort now. What we're doing here is we're applying positive airway pressure throughout the whole respiratory cycle to a spontaneously breathing patient. And that's the key. The patient has to be able to breathe on their own. This is a pressure device. It's not a ventilator, okay? So the patient has to generate their own ventilations. What we're doing is assisting with some pressure to help keep that airway open throughout the respiratory cycle. And if you look at kind of how this works, the increased pressure increases the ability of oxygen to transfer from air into the blood. And so if you think about the little alveolar sacs in the bases of the lung, kind of at the termination of your airways, kind of like a balloon, okay? And if we picture somebody here that has congestive heart failure, and that balloon is kind of full of water, you can imagine a deflated balloon would kind of just stick together. But if I inflate just a little bit of air in there with a little bit of pressure and that balloon opens up, that water then displaces, and that'll allow for more surface area for gas exchange, and that makes the patient able to breathe easier. So, as shown in that picture there, this little bit of extra pressure increases the size of the alveoli a little bit, displaces some of that water, and it makes it easier for the patient to breathe. Now, when can we not use CPAP? Obviously, we can't use CPAP if the patient's not breathing. This is not a ventilatory device. The patient has to draw their own breaths, and if they don't do that, then we need to use something like an ambu bag. If the patient has a pneumothorax, that's a problem because if we're increasing the pressure that we're blowing into the patient and they have a hole in their lung, that's going to make things more difficult for them to breathe, and that may make that pneumothorax worse. Nausea and vomiting is another contraindication. If they're going to fill the mask up with vomit, not a great idea to strap it to their face. Now, we can use it in patients with COPD and asthma, but we have to use caution in those patients because, again, we're talking about already distended airways, and now we're distending them more with pressure. That could cause barotrauma or a pneumothorax. Doesn't mean we can't use it. It's just something that we have to be careful to watch for complications when we do. Now, let's talk a little bit about breathing made simple, okay? This is as easy as I can make it, all right? Oxygen goes in, all right, and then carbon dioxide comes out, okay? The process of oxygen going in is called oxygenation, and carbon dioxide coming out is called ventilation. And those are two important concepts that you need to keep separated. Now, how can we influence oxygenation? Oxygenation, or the oxygen that's going in to the lung, is determined by the pressure. So, we can do things like PEEP on a ventilator or CPAP that we already talked about. Or we can dial up the FiO2, or the fraction of inspired oxygen. And again, room air, 21%, we can increase that with those devices that we talked about. We measure oxygenation with a pulse oximeter, okay? So it doesn't matter how many times you squeeze the bag. As far as oxygenation goes, it requires how much, it's determined by how much oxygen is going through the mask into the patient's lungs and what the pressure of that oxygen is. And so again, we measure this with a pulse oximeter. Now the pulse oximeter has some limitations. We've all know that motion, especially in the back of an ambulance, it may be difficult to get a good reading. Nail polish sometimes affects things. Anemia can affect the pulse oximeter. And in carbon monoxide poisoning, we may actually see a false high reading. So there are a few problems when the pulse oximeter is not great. Now ventilation, as we said, is carbon dioxide leaving the body, okay, through the lungs. This is determined by the tidal volume and the respiratory rate. So when you hyperventilate, you are blowing off more carbon dioxide, therefore you get hyperventilation syndrome. So again, ventilation determined by tidal volume and respiratory rate, and it's measured by waveform capnography, which again, I think most of us are carrying now in the ambulance, and also by the end-tidal CO2. Carbon dioxide is a byproduct of metabolism, okay? It's excreted by the lungs with every expiration. Now, normally in the air that we breathe, there is very little carbon dioxide. But when we exhale, there's a significant amount of carbon dioxide, and we measure that with our waveform capnographer, and we'll go over those tracings here in just a second. The normal range of carbon dioxide in the blood is 35 to 45 millimeters of mercury. The normal range of exhaled carbon dioxide, the end-tidal CO2, is 35 to 45 millimeters of mercury. Now, what can cause an elevated end-tidal CO2? Hyperthermia will increase it. Any kind of altered mental status where you have respiratory depression. Remember, we said carbon dioxide leaving the body or ventilation is determined by the tidal volume and the respiratory rate. So if you have a low respiratory rate or a low tidal volume because of altered mental status, that will raise your end-tidal CO2. Hypoventilation, pretty much the same thing. Obstructive lung disease, it may be compensated, okay? So you may have someone with a large end-tidal CO2 and they may run there all the time because they are CO2 retainers because they have COPD. So again, you'll see high numbers in those folks. So what causes decreased end-tidal CO2? Hypothermia will do that. Cardiac arrest. If you are not generating adequate circulation because the heart is stopped, then blood cannot get back to the lungs, and CO2 cannot be cleared from the body and measured as end-tidal CO2. This is also a good indicator of ineffective CPR. So if you're doing CPR and you're not effective, you're going to see a very low end-tidal CO2. If you're doing CPR and that end-tidal starts to rise toward normal rates, that would be a sign that you have effective CPR, you're generating effective circulatory response, and you're perfusing the lungs well, and then you're getting a release of carbon dioxide into the lungs, and you can measure that as end-tidal CO2. Now, what about sudden hypovolemia or hypotension? That can sometimes cause a decreased end-tidal CO2, again, because we're not perfusing the lungs well. Hyperventilation syndrome, again, we say that ventilation is determined by respiratory rate and depth. And so if they are generating a large tidal volume or a large respiratory rate, because they're hyperventilating, they're going to blow off carbon dioxide, and you're going to see a low end-tidal CO2. Now, asthma, early on you'll see a low end-tidal CO2, but as they get worse and as they start to fatigue, you're going to see a decreased tidal volume, a decreased respiratory rate, and you're going to start to see that end-tidal CO2 rise. And that's usually a bad sign and a late sign, and a sign that maybe we've got an impending respiratory failure. Now, diabetic ketoacidosis, that's another time we see end-tidal CO2 rise. And what's happening here is the patient's blood is acidic. They're trying to bring that acid-base ratio back more toward normal. And so you'll see those frequent deep breaths that the patient's taking to blow off that excess carbon dioxide and try and lower that CO2 as low as they can to compensate for the acidosis. And they may look short of breath, but a lot of times when you ask those folks, are you short of breath? They will say no. This is just their body's compensatory mechanism that is they're subconsciously breathing fast and deep to blow off some carbon dioxide in an attempt to achieve a decent acid-base status. Okay, this is waveform capnography. Hope we're all familiar with this. You see the gray and the white areas there. The gray area is exhalation, the white area is inspiration. And you see as we breathe, the first phase is where we see A there, and that's our respiratory baseline. So just basically free gas is being expelled from the anatomic dead spaces, okay? And that is very low in carbon dioxide because it's just free gas, just like the air that we breathe has very, very low carbon dioxide. In phase two, through exhalation, we start to see things elevating there, and you see a very steep rise. That's exhalation of the dead space, and now we get the alveolar CO2. And so as that alveolar CO2 starts to be expired, we're going to see a rapid rise in the amount of carbon dioxide in that air, and that will be measured up to about C. Now from C to D, that's what we call the plateau. Here you have expiration of only alveolar gas, and again, that's very high in CO2, and the number will start to rise a little bit. We have much less dead space air, and so when we get to point D, that is the end tidal CO2 number, okay? So that's what we refer to as the end tidal CO2. So if you have a monitor that's not showing you the waveform, just showing you the number, that's what the value that you're getting on that monitor is the part where we're at D there. Now, in phase four, we inspire, we breathe in. And so we said that most of the air that we breathe has very, very low concentrations of carbon dioxide. And so we see a rapid drop down to E there. And then we start the whole cycle over again. Now, how can we use waveform capnography? You know, this is kind of the gold standard for verifying endotracheal intubation, okay? You should, every time you intubate somebody, and even if you're using a supraglottic device, measure either waveform capnography or at a bare minimum have an end tidal CO2 calorimetric device that changes color to indicate the presence of carbon dioxide. It really is the gold standard, and if you can record this, if you have the ability to record this inside your EPCR, that's always good for you to prove that that airway was in the right place, okay? If you have a sudden loss of waveform, that really should be concerning for a displaced tube. You see there in that graphic, we've got the nice plateau that we just talked about, and then all of a sudden we've got a bunch of garbage. And so you got to really worry that maybe that tube became displaced or obstructed, or there's some kind of problem in the circuit. We got to make sure that we look at all that. You can't just ignore that. A lack of a waveform may be a good indication of esophageal intubation. I mean, if you never see that plateau and you just see kind of that garbage to the right there on that graphic, you got to really question whether or not you're in the right place with that AT tube. And again, use this with your supraglottic airways. If you got a good seal, you should see a very similar waveform. Now, what happens when we see the shark fin waveform? Here we see that plateau is gone, and now we see kind of this little shark fin look to the waves. That indicates bronchospasm. So this is an asthma patient. This is somebody with COPD. The bronchospasm prevents the sudden rise in exhaled CO2. It's more gradual, and so you don't see that normal waveform. You see this kind of sloped shark fin. That's one way you can kind of look at this when you're measuring this on your patients, is how much that may indicate a lot of bronchospasm. What else can we use waveform capnography for? Well, you can use it with patients with altered mental status to see if they need ventilatory support. If you start noticing an increase in the end tidal CO2 in someone that has altered mental status or even respiratory distress, that's an indication that they're going to need ventilatory support. They are starting to fatigue on you, and you need to address that. You can assess for DKA. Remember we said in diabetic ketoacidosis, the end tidal CO2 gets fairly low, and if you have somebody that has the signs and symptoms of DKA, you measure a blood sugar, it's critically high, and you check their end tidal CO2, it's very low. Chances are you've got a patient here that's in DKA, you've made your diagnosis. You can monitor for hypo and hyperventilation in patients with high intracranial pressure. We try not to hyperventilate folks too much anymore with high intracranial pressure, because we know if we hyperventilate them too much, that intracranial pressure will actually rise. But we do want to hyperventilate them a little bit. And so we can monitor this waveform capnography to kind of make sure we don't overly hyperventilate them. And also we want to make sure that end tidal CO2 doesn't rise because we're hypoventilating the patient. So it gives us a way to monitor that. You can also monitor asthma patients for response to therapy. Do they have that shark fin that later becomes a plateau? Or is their end tidal CO2 low and now it's starting to rise, indicating that they're fatiguing out and that they're getting worse? Now, how do we use it in cardiac arrest? Capnography is a good measure of cardiac output, as I said, if the airway is placed correctly. So it helps you measure your effectiveness of CPR, and you can spot compressor fatigue. I've seen this multiple times when I've been out in the field watching cardiac arrest. If you got somebody that starts to get tired, that end tidal CO2 will start to drop. And as soon as they start kicking in with better compressions, it will start to rise, okay? Really pay attention to that. If you, and again, this only works if you get a good airway place and get good waveform capnography. Now, when you get ROS back, you may all of a sudden see a jump in that end tidal CO2. So if you got someone you're not sure about PEA, you're not sure if you feel a pulse, obviously you should always do CPR in that case. But if you notice that the end tidal CO2 has gone from 30 to 45, that may be an indication that suddenly the patient has got a pulse that's perfusing. It may also be an indicator of poor outcome. All right, there was one study that was done that showed 100% mortality at 20 minutes if the end tidal CO2 was 10 millimeters of mercury or less. So again, we've only got a limited amount of time to resuscitate these folks. If your end tidal CO2 is poor, you're not only not perfusing the lungs, you're probably not perfusing the brain and the rest of the body with your CPR. That's a problem. This is an area of continuing research, though. That everybody wants to know the magic number and the magic rhythm when we stop resuscitation, and nobody really knows that. There's a lot of theories on that right now, but there's a lot of differences between the actual presenting rhythm and what the rhythm the patient is in when you decide to call the code, and also your levels of end tidal CO2. So stay tuned for that. I think in the next 5 years, maybe 10 years, we're going to learn a lot more about that. But right now, use this end tidal CO2, assuming you have good capnography, as a good measure of how effective your CPR is. All right, you can also use capnography in malignant hypothermia, okay? I don't care about that, and you shouldn't care about that, all right? I'm hoping to stick with this lecture, just focus on what you need to know, okay? Don't get lost in the weeds, okay? If you're using capnography to diagnose malignant hypothermia, you're a smart guy, that's fine. But I'm trying not to confuse people too much. So basically focus with waveform capnography on knowing really well what I just told you and not worrying so much about what you don't need to know. All right, let's talk about the causes of shortness of breath, okay? This may be a single isolated cause or multiple factors. Obviously, if you have someone with COPD that also has pneumonia, that can cause multiple different problems. They have multiple different diagnoses and multiple different treatments. Some diagnoses are a lot easier to treat in the field than others. I mean, we're all familiar with the using CPAP to maybe reverse hypertensive crisis with a congestive heart failure patient, or given an albuterol treatment for somebody with asthma. But it's pretty hard to treat pulmonary embolus when you're out there in the field. So again, there's not a lot you can do for some of these patients. There is some things we can do when we encounter some of these folks. So let's look at the left photo there. This kind of explains the mechanics of breathing, okay? So when you breathe, you're inhaling air into the lungs, okay, and the lungs fill. They don't fill because the lungs do anything, okay? They fill because the chest wall and the diaphragm lowers, and that pulls negative pressure, and that allows air to enter the lungs, okay? So it's kind of like when you're drawing up a syringe. It's the same process. As you move the plunger down, that creates a negative pressure, and air will naturally just fill the lungs. When you exhale, your lungs empty because the diaphragm rises and your chest squeezes. It pushes air out of the lungs. And that's kind of how respiration works. Now, that comes into play when we talk about things like pneumothorax and things we'll talk about here in just a minute. Okay, let's look at the right picture there. This is the airway anatomy. You see the air comes down through the trachea into the left and right lung via the bronchi. The right lung is the larger of the two lungs. It does about 55% of the work and has 3 lobes, the upper, middle, and lower. The left lung does about 45% of the work, and it has an upper and a lower lobe. You see that the bronchi become progressively smaller to where they become bronchioles, and eventually those bronchioles terminate in the alveoli, which are the little grape-like clusters you see in the bottom right there. That's where gas exchange occurs. Now, blood going to the alveoli is very high in carbon dioxide and very low in oxygen. Now, air going to the alveoli is very high in oxygen and very low in carbon dioxide. And so that gradient there allows gas to diffuse across the membranes there in the alveoli, which will allow the return of a high oxygen, low carbon dioxide blood back to the rest of the body. One thing to remember when you see a patient with myocardial infarction is that shortness of breath alone, even in the absence of chest pain, may be a sign of myocardial infarction. So make sure any patient that has shortness of breath gets an EKG, even if they are pain-free. That's a mistake you don't want to make. So be looking for myocardial infarction in your patients that present with dyspnea. Now, congestive heart failure can cause shortness of breath. The heart's ability to pump oxygen rich blood does not meet the body's need in congestive heart failure. So you're trying to pump out this oxygen rich blood to the rest of the body, but the pump is ineffective, and so you have problems. Numerous causes can cause this. Myocardial infarction can do this, cardiomyopathies, valvular disease, lots of different things. Um, Excess fluid can accumulate behind the affected heart chamber, which will cause swelling in the lower extremities if it's a right sided heart failure. But if it's a left sided heart failure, you may see this present as fluid that's building up in the lungs because the left ventricle is not able to pump adequately. And so those folks will need CPAP. They'll literally be drowning in their own fluids. And so, that's what's causing their shortness of breath. Here we see right-sided congestive heart failure, where we have failure of the right side of the heart. This leads to fatigue and edema in the lower extremities, and in severe cases, the abdomen. And then here's left-sided congestive heart failure. We have the left side of the heart failing, fluid backs up into the lungs, and this causes pulmonary edema, which you see in the chest x-ray there. These patients need CPAP. They can be extremely short of breath. If you have severe left-sided heart failure, that can also lead to right-sided heart failure. So these patients are going to present with shortness of breath, dyspnea on exertion, what we call paroxysmal nocturnal dyspnea, where they wake up suddenly short of breath in the middle of the night, and coughing. Now, the one thing you do not want to miss if you're out there practicing, especially in the middle of the night, is a hypertensive crisis. Okay, what happens here is the patient goes to bed, they lay flat. Instead of gravity pulling all of that blood and fluid down to their feet, the blood returns back to the heart because the patient is laying flat in bed. And what happens there is the heart cannot pump out that blood adequately, and it starts to back up. And so these patients wake up in the middle of the night with some shortness of breath. That causes anxiety, and that anxiety causes high blood pressure. That high blood pressure makes it much more difficult for the heart to pump out against the pressure, and so more fluid backs up into the lungs, and this cycle kind of spirals out of control, where they have increased anxiety, increased hypertension, and it gets very quickly to respiratory distress. And so what you find here is a patient who's extremely hypertensive. They're very short of breath. They're in severe respiratory distress. These folks need dilation of the peripheral vasculature and a decrease in their peripheral arterial vascular resistance that is best done with nitroglycerin. So get them some nitroglycerin, get their blood pressure down. CPAP will buy you some time to accomplish this. Now remember, we said CPAP is not a ventilatory device. The patient has to be breathing, okay? But a lot of these patients, if you treat them aggressively, you can put the CPAP on them, get them some nitroglycerin, and that pressure will start to come down. Give it every 5 minutes, give it frequently. Now, I know most of you are not carrying IV nitroglycerin, and so you will have to break the seal on the CPAP every 5 minutes to give them one of these nitro pills sublingually or some nitro spray. That's okay. Just don't do it any other time, okay? But really, you need to get that pressure down, and the CPAP is just buying you some time to accomplish that. The big thing is, though, you do not want to miss this. My first question, anytime that I get a respiratory distress patient after hours in the middle of the night, is what is their blood pressure? The wrong answer in this situation is to put a neb treatment on some guy who has never had asthma or COPD in his life and is extremely short of breath, and his blood pressure is 200 over 100, and we're not treating the underlying problem, which is hypertensive crisis. Now, nitroglycerin in low doses is going to dilate the venous system, and that's going to result in an increased venous capacitance and reduced blood flow to the right ventricle. Now, this reduction in the right ventricular preload, in turn, is going to result in less blood flow through the pulmonary vascular bed and ultimately less outflow to the left ventricle. When we give nitro in high doses, that causes dilation of the arterial system, so reducing peripheral vascular resistance, increasing forward flow, and ultimately it's going to decrease the workload of the weak and damaged left ventricle. Nitroglycerin is the only drug here that has been shown to reduce mortality in these patients. It is the antidote to hypertensive crisis causing hypertensive congestive heart failure, okay? So, you need to give these patients nitroglycerin even if they don't have chest pain. Now, what about morphine? We used to give a lot of morphine to these folks. This was long thought to aid in vasodilation while simultaneously decreasing their anxiety.
But what we found is that basically the vasodilatory effects of morphine are transient and they're frequently overstated. The other problem you have is if we give these folks some respiratory depression or CNS depression, again, and they're on CPAP, that can cause their ventilatory drive to kind of pewter out, and that results in increased intubations and lengthy ICU admissions. Most of these patients, if you hit them aggressively with nitro and with CPAP, can be on a nasal cannula speaking normally a lot of times before you guys even are done with the cleaning up the rig and leaving the emergency department. So, this is something that you need to be very aggressive in treating. Morphine, not as good as we once thought it was. All right, what happened to Lasix? We used to give Lasix all the time. And the assumption here was that the pulmonary edema results from excess total body fluid. And what we found is that's really not true. Most chronic congestive heart failure patients who are pretty well managed are either euvolemic or sometimes are even a little dehydrated. This acute pulmonary edema is likely less of a fluid volume problem than a fluid distribution problem. The blood pressure went up, usually from anxiety, and the cycle spun out of control. It's not that they have too much fluid; it's that their heart is unable to pump against the hypertension. So again, Lasix, not great. It may even be harmful to the patient. In researching this lecture, I looked at one EMS paper, and this was a direct quote. Proper diagnosis of volume overload requires laboratory testing beyond the capability of most EMS systems, and misdiagnosis of acute congestive heart failure can be disastrous with Lasix in the armamentarium. And that's very true. I mean, we do a lot of blood work, we do chest x-rays, we do a lot of things that you guys cannot do in the field before we decide to give Lasix. Also, the onset of Lasix, it takes a while, and a lot of times, most of the services we deal with have short transport times. And so the problem is let's say this person turns out to have sepsis, and they're having a bad pneumonia, and it's not congestive heart failure. Well, if you've given them Lasix and dried them out, that can make the sepsis much worse, and just like the article says, can be disastrous. So again, that's why we took Lasix off of the truck. That's why most EMS services no longer carry it, because it can be an absolute disaster if you give it to the wrong patient. Now, COPD, we see this a lot. This can also cause shortness of breath. Here we have airway obstruction, which is progressive. Sometimes it's reversible with treatment, and usually we use bronchodilators and steroids to do that. The most common forms of this are emphysema or chronic bronchitis or some combination of both. Emphysema, basically here you have your pink puffer. These folks are skinny. They're not usually cyanotic. They have a very quiet chest. 90% of these cases are caused by smoking. They have abnormal and permanent enlargements of the air spaces in the lungs. And I think we've all seen this guy just has big, boggy lungs that are enlarged but does not get cyanotic. That's why he's a pink puffer. Now, with chronic bronchitis patients, and sometimes we'll see acute bronchitis, these folks have inflammation of the tracheobronchial tree. And so the acute bronchitis, it's due to a virus. You get a cough, a runny nose, some wheezing, a little shortness of breath. You may have normal breath sounds. But when the chronic bronchitis folks that have COPD, when we see those folks, these are your blue bloaters. They're cyanotic, they have a productive cough, they're overweight, they have very noisy chests due to rhonchi or wheezing in those upper airways. All right, asthma can also cause shortness of breath. Here with asthma, we see an inflammation of the airways due to a hyper-responsiveness of the tracheobronchial tree to various stimuli. This causes shortness of breath, wheezing, and cough. Now remember, the lack of wheezing does not mean the patient isn't in significant distress. Some of these quiet chest folks can actually be very significantly ill, and we need to treat that aggressively. Remember, we mentioned checking the end-tidal CO2 in these patients that are in distress, and if you see that end-tidal CO2 starting to climb in an asthma patient, especially a young asthma patient, that's a sign that they're not doing well. The treatment here again is bronchodilators and steroids, and you see what the airway looks like there in the photo. A normal airway is nice and open, whereas an airway in a patient with asthma has very tight muscles, it's swollen, and there's a lot of mucus secretions that kind of narrow that airway. What else causes shortness of breath? Pulmonary embolism does. Here you have a blockage of a pulmonary artery. This prevents blood from going back to the lung. So obviously, if we can't get blood back to the lung, we can't get oxygen to that blood, and therefore we have a problem giving adequate oxygen to the rest of the body. 90% of these are caused by migrating deep venous thrombosis. So, I think we've all heard people that have had blood clots in their legs. The leg is the most common cause for these, the most common area for these migrating deep venous thrombus. The thrombus in the leg is not the problem. It's when it decides it's going to travel up to the lung, it goes through the right heart, it goes out to do the pulmonary vasculature, and eventually it lodges somewhere, causing a pulmonary infarct. Now, these can be lethal. They can also be very subtle. If it's a very small clot, the patient may not even notice. If it's a very large clot, it may present as a cardiac arrest. So again, you can miss the diagnosis here because sometimes these patients come in with nonspecific signs and symptoms, and then half of these are asymptomatic with no symptoms at all. The treatment for pulmonary embolism is anticoagulation. Risk factors for pulmonary embolism are people with cancer, anybody that has a family history, immobility, surgery, recent surgeries, smoking, pregnancy, and any kind of hormone therapy, like hormone replacement therapy or birth control or that kind of thing. And actually, I put this picture in here because when I was looking for pictures of pulmonary embolism, this was the #1 hit on Google Image, was this guy. So I figured to put him in my lecture. All right, let me give you a hypothetical case example here. Let's say you have a 41-year-old male with a history of lung cancer who's on chemotherapy that regularly leaves him bedridden for a week every 3 weeks. 6 weeks status post major chest surgery, has a few risk factors here for pulmonary embolus. He gets a sudden onset of atrial fibrillation with rapid ventricular response. He has no shortness of breath, no leg pain or swelling, and he is found to have 2 pulmonary emboli. So, of course, obviously, this was me last year when I had my pulmonary emboli. It to me just presented as AFib with RVR. I had no other symptoms, had no shortness of breath, no leg pain, no swelling, and luckily we caught that. But again, these can be very subtle, and a lot of them are asymptomatic. Now, pneumonia can also cause shortness of breath. Here, what we're talking about is inflammation of the lung from either a bacteria or a viral infection. You can also see this with aspiration in your debilitated or nursing home patients. And a lot of times when you see aspiration pneumonia, you'll see it in the right lower lobe. And the reason for that is, as you see in the drawing there, the right mainstem bronchus comes off at a very shallow angle. And if you're going to aspirate something, it's usually going to wind up in the base of the right lung. Whereas the left mainstem bronchus comes off at a much steeper angle, it's much harder to aspirate into that left lung. Pneumonia presents as shortness of breath, fever, cough, and sputum production. Usually they'll have rhonchi, wheezing, or decreased breath sounds when you listen. The treatment here is antibiotics and bronchodilators. Pneumothorax can cause shortness of breath. Remember, these are, a lot of times we think of traumatic pneumothorax, but you can have a spontaneous pneumothorax as well. Risk for a spontaneous pneumothorax would be anybody who's male, a smoker, tall, skinny, 20 to 40-year-old, somebody who's COPDer, as well as a history of previous pneumothorax. Those folks are all at risk for spontaneous pneumothorax. Now, a tension pneumothorax is when that spontaneous pneumothorax accumulates so much air between the lung and the chest wall that you start to see tension on the heart and vessels inside the chest, and you'll also see complete collapse of that lung. And so what you see there in that chest X-ray, this is obviously a traumatic tension pneumothorax. You see, you've got multiple broken ribs on the patient's left side there, on the right side of the film, and then that whole left lung of the patient is completely full of air, and the lung actually itself is completely collapsed. The heart is displaced over to the patient's right, and all the vessels and the airway and everything are pushed over there. This is an X-ray that you never want to get because it's a sign you should have treated this a long time ago. But if you see a tension pneumothorax, that needs immediate decompression. So signs of a tension pneumothorax would be distended neck veins, tracheal deviation. I will tell you right now, though, the reason I crossed this out is the only place you're going to see tracheal deviation is on a test. You will never see it in real life. If you claim to see it, I don't believe it. It is something that is not a reliable indicator of tension pneumothorax. So we call it kind of a unicorn. It's out there in theory. If you see it, take a picture of it. I'd love to see it. But I do not wait for a deviated trachea before I treat a tension pneumothorax, okay? As far as I'm concerned, you'll only see that on the test. And if you ever see it in real life, you've waited way too long to decompress the chest. Now, you may also see tachycardia, again, shortness of breath, and then the absence of breath sounds on the affected side. The other thing you'll notice in that chest X-ray there If you look to the right side of the film, the patient's left, right in the area where those rib fractures are, you see that it kind of looks like a little bit of Rice Krispies there in the subcutaneous tissue. That's subcutaneous air. And so if you ever have a trauma patient and you're running your hands, I know God forbid touch the patient, but if you run your hands along the chest, either anterior or laterally or even posteriorly, and you start to feel kind of this Rice Krispie crunchy sound underneath the skin there, you've got air where it shouldn't be. And so there's a hole in something, and it's most likely going to be a pneumothorax or some kind of airway injury. So be mindful to look for that. Okay, how do we decompress the chest? The traditional way of doing it is doing a needle decompression in the second intercostal space in the midclavicular line. You see our in that picture there, right where that guy has his finger. That's pretty much the second intercostal space, and it's right there in the midclavicular line. You're going to use a 14 gauge IV catheter that is at least 3.5 inches long. The regular ones that you use to start an IV are not long enough. You need the long catheters. You're only going to do this if a patient is unstable. Not everybody with a pneumothorax needs a needle decompression in the field. We're only looking to decompress tension pneumothorax. So again, usually not needed for spontaneous. These are usually going to be traumatic pneumothoraces that have progressed to tension and now need decompression. All right, so that's kind of a review. Let's go over the questions here just a bit. What 2 treatments should be initiated for a person with acute pulmonary edema with hypertensive crisis in respiratory distress? And again, if you get nothing else out of this lecture, I want everybody to remember this. In the middle of the night, when you get there and you see a guy with sky-high blood pressure and respiratory distress, be thinking these 2 interventions. And they are nitroglycerin and CPAP. Remember, nitroglycerin is the only drug that's going to reduce mortality in these patients. CPAP is going to buy you some time to get that blood pressure under control and hopefully keep them off the ventilator and out of the ICU. Here's question 2. You suspect a spontaneous pneumothorax in a tall young male with sharp pleuritic chest pain and mild shortness of breath. You most likely will need to do a needle decompression in the field. And that is false, okay? Most spontaneous pneumothoraces do not need a needle decompression because they don't progress to tension in the field. They're much slower. Traumatic pneumothorax, a lot of those don't need needle decompression, but some of them will present as tension pneumothorax. If they're under tension and the patient is in distress, they need needle decompression. Okay, shark fins on a waveform capnography indicates what? There we see our shark fins, and that's going to indicate bronchospasm, okay? Remember, we said that the airways are narrowed, so it's going to present as that shark fin pattern on our end tidal CO2. All right, you are bagging an intubated patient when the waveform capnography suddenly looks like this. What life threat do you want to rule out? Okay, well, we see we had a nice plateau there. We had a very good looking waveform, and all of a sudden our waveform has disappeared and we have that kind of garbage look to it. We want to rule out a displaced ET tube or an obstructed tube or any other problem in the circuit. But the big one is displaced ET tube. If we can't prove that that ET tube is in the right place, we cannot leave it in place. We have to start over. Question number 5. All patients with shortness of breath or critical illness should be placed on high flow oxygen via non-rebreather mask. Remember we said that's false, okay? Just because you're short of breath doesn't mean you need oxygen, okay? Again, we only provide additional oxygen when your oxygen saturation falls below about 92. And I would make the argument you can let that fall to about 88% in your COPD patients. We do find now that some of these patients do worse when we try and shoot for very high pulse oximetry readings. Don't just treat the patient with oxygen just because the patient says they're short of breath, okay? This may be somebody that has anxiety, maybe they're hyperventilating, or they may have a symptom like a myocardial infarction, which will do worse when given lots of oxygen that they don't need. So again, not necessarily need to put these patients on high flow oxygen just because they say they're short of breath. All right, well, that's all I have today. Thanks for listening, and if you have any questions, feel free to contact me.